Now, I'm going to give you the choice about whether you want to give us a few minutes on your vision of better collaboration to improve patient outcomes, whether you want to do it from the lectern or whether you want to do it from these comfy black chairs. How are you feeling? I'll ask you first, Stephen. What do you fancy?
Comfy chairs.
You fancy comfy chairs? I know, it's got that sort of morning after feeling.
Do you agree, sir? Yes. We're happy with comfy chairs.
I'm going to give you advance warning at some stage, Steve. I'm going to ask you about the front page of the Daily Mail, which has been perplexing us so much. Do you want to get that out of the way first, or do you want to give us a little overview first on collaborating?
Front page of the Daily Mail.
Yes, I'll just remind you, new cancer drugs held up by the NHS for 9 years.
Yes, I did not see that until it arrived.
Okay.
But having looked very quickly and having had a conversation quickly this morning, the research survey seems to include a lot of medicines that existed before NICE existed, including Taxol and things like that.
Okay.
It also doesn't seem to take into account the fact that obviously appraisals are stopped and started during the whole process, often by the companies themselves. So other than that, I think it also started in GP magazine, and I think the survey was done was concluded in January this year. So it's not something that I recognise or something that the ABPI necessarily supports. It certainly didn't originate with the ABPI, and that's probably the best thing I could say. And it doesn't seem to reflect the fact that NICE came into existence in 1999, not in the early 1990s when some of the drugs it mentions looks at.
Was anyone from NICE consulted about this before it went to publication? Don't know. Okay, well, there we go. So don't always believe what it'll serve you right, Mike, for praising the Daily Mail yesterday. It's come back to bite you, hasn't it? But should look into this. More information needed. Okay, let's be constructive. We're talking about collaborating to improve patient outcomes, a better relationship between industry and the NHS. How do you see the relationship at the moment, and how could we improve it?
I think the relationship between the industry and the NHS is significantly improved. I mean, I left the industry in 2003 and then went into financial services and came back into this role 1st of June last year. And I think one of the things that struck me was just quite how changed that relationship was. It's very much, I think, from a transactional buyer-seller relationship to a much more cohesive and conducive partnership-based relationship with some quite excellent examples of that partnership in place. I could use one case as a case study, if you like, for which was there's various joint working processes in place between the NHS and pharmaceutical industry, and including the device industry as well. And clearly there's self-interest in it. I'll come to that in a minute. But the joint working framework that's been put in place between the DH, the NHS and the industry has been put in place for a purpose, which is to draw best practice from all sides to collaborate and share. I think one of the most recent examples I've got is the Wallasey Health Alliance Stable Angina Plan, which basically the Wallasey Health Authority has a population of about 60,000 it covers, had a significant angina problem and an undermanaged angina problem, and too many referrals to secondary care, too many hospitalisations were going on, enormous cost. Clearly sitting at the centre of a lot of this is high quality medicines, and what we were seeking to do through the joint working programme with Wallasey, and it's one specific member company, it's Servier, what we were seeking to do was to demonstrate the value of the medicine, because it avoided referrals if effectively utilised. And so what we did was put in place a joint working programme. It included a lot of things like exercise, so it wasn't just about the medicine. It included focusing on the patient and drawing the right patient into primary care and away from secondary care. Some data that came back, and I'm always very suspicious of data like this, when it said that 100% of patients felt more in control. Now 100% sounds to me like a Zimbabwe election, but it's certainly quite reassuring. I think more specifically and more helpfully was that there was a 20% reduction in coronary intervention in secondary care. And there was also a 60% reduction in stable angina emergency admissions. Now altogether those two things saved £85,000. That's of significant benefit because it reinforces primary care. It also reinforces the value of the medicine. Often there is a reluctance within the NHS to partner with pharma, and I think a lot of that goes back to historical baggage about our reputation, which I think has significantly changed, but I think the reputation lags. There is a range of specialist tools out there that can be utilised, and I would always encourage to learn from best practice within the NHS itself. So the Wallasey is an example, there's a COPD example that's running in Surrey at the moment, a lot of work in diabetes, a lot of work in areas that we know is most cost effective and most better managed in primary care. The guidance exists. We've also established at the ABPI, it's a significant investment for us, a regional team existing of 5 people called ABPI NHS partnership teams, which are not product specific, but they're looking at partnership principles to see how we can make this really get engine behind it. We've also established a partnership with the NHS Confederation looking at pilots, again, to create the pull factor within the NHS rather than diktat and push. So that's key. The other thing I would also add, and it's something I know Mars is going to cover, is that the NHS, as a research body, I think we have to really focus and really get moving on. The industry clearly wants to utilise the NHS properly. We are losing our place as a global leader, particularly in phase 2, phase 3 in the UK. We need to regain that. A lot of work is going on with the NAHR, the new Health Research Authority. The industry is keen to partner on this, and there is commercial benefit to be had by the NHS if you can gear up effectively to this partnership. Now, I started off by saying clearly there's something in it for us, because of course there is, otherwise we wouldn't do it. We believe in the effective use of modern medicines. We believe and we know they save costs elsewhere in the system, and joint working enables us to demonstrate that through a catalogue of evidence that we can demonstrate and provide, and we have on our website and we have through our regional partnership teams that demonstrate effective care in primary care, often putting medicines at the centre. Not always about medicines, often patients don't need those medicines yet, but they need monitoring and managing. So there is value in it for us, but we also believe there's value, there's shared value also in partnership with the NHS. That's really what I wanted to say, Phil.
So if you're partnering with one particular company, how do you avoid the vested interest or the pressure of prescribing the products from that particular company?
Well, there's very careful management and guidelines around that, because of course one specific company is interested in its medicine, but of course the prescriber is the final authority on that and will choose from a range of medicines that are most suitable for that patient. Because we as an industry can't choose what's right for a patient, we simply offer a range of medicines that can be most effectively utilised. It's not about selling one specific product. It's actually about raising the awareness of the disease and avoiding secondary care interventions where possible.
So when, I think Wallasey, you said, partnered with Servier.
Servier
did they put it out to tender, and were there 5 or 6 companies all tendering for that partnership, or did they?
Servier initiated it, but it's not about Servier's product, but I'm sure Servier did sell more of their product in that area, but it's not about, it's the product choice remains the choice of the clinician. Nothing is stitched up, if you like.
Okay. Well, I suppose that moves us nicely on to Miles Scott, who's Chief Executive of St George's Healthcare NHS Trust, who can talk about it from the NHS perspective. Tell us your views on this and whether you have any specific examples in St George's of this collaboration going on.
Sure. Thanks, Phil. So, I mean, I think the context for this debate is pretty well trodden, actually, in terms of, it seems to me there's been a growing appreciation in recent years of the benefits both for the health of our population and for the wider economy of us having a more functional relationship between the NHS and industry. I think that in the last few years, the NIHR, the major charities, the AHSCs, many others have made a lot of progress in this regard, and I think particularly in tackling the first gap in translation, it seems to me that a lot of progress has been made. But I think there's an increasing concern about the ability of the NHS to adopt and take up those things that actually do work for the benefits of people, and also a concern about the NHS ability to really change itself in addressing both the health and the financial challenges, and I guess the latest iteration of that then is that concern is the whole innovation, health and wealth agenda, and the development of academic health science networks. So I guess I'm going to answer a question with a question, or a series of questions really, which is, I've got 3 questions for my colleagues and for the audience, and maybe one kind of proposition that I'd be keen to float. I think the first question is around academic health science networks, and my question about whether do these represent an opportunity or are they just simply a complication in taking this forward? If we accept the premise that closer collaboration between the NHS and industry is a good thing, are AHSNs going to be useful in that? Certainly there seems to be a lot of enthusiasm at the corporate level, if you like, of both NHS organisations and indeed universities for these networks. So you've got real interest from chief executives and vice chancellors and so on. And there ought at least to be the opportunity to force the pace on governance, time to recruit, uptake of studies, there ought to be the opportunity to have more formal vehicles to pursue the adoption and spread of innovation, and also I think an opportunity to engage more effectively beyond the pharma industry, particularly with the devices sector and the IT sector, where I think there are less well-established networks for us to engage in. But all of that's kind of quite theoretical, and I think we need to understand how we can actually make these kind of collaborative structures work, either for the NHS or for industry. And it seems to me that quite a few of the things I've listed there are things that the NIHR and the local comprehensive local research networks have been engaged in plugging away at for a number of years, and I think they've had quite a bit of success in that. And the extent to which that success has been constrained or limited, I think we need to be clear why we think the AHSNs will be different. So first question is, AHSNs, are they an opportunity or are they just a kind of a bureaucratic complication? I think my second question is, I think we need to be very clear, or ask ourselves, are we clear what we mean when we say we want much wider participation in clinical trials in particular? Certainly from my experience, there is, in relation to commercial studies in particular, there is a tendency for companies to focus very much on relationships that they know, and people they know well and trust and like. And that's often represented if you look at the NIHR portfolio, for example, that where there are commercial studies on the portfolio, they've often got pre-selected sites. And so for a lot of academically minded clinicians, particularly relatively recently appointed consultants, and many of these people are consultants, it can feel like it's very difficult to break into that. So if we're going to exhort this kind of much wider engagement and participation in studies, we need to be sure that we all mean it, and that we're going to take that forward. I think we need to understand why companies want to go with people they already know, both in terms of they know they can trust them to recruit and all that sort of thing, but also they very often know that these guys are the opinion formers, and that's going to be quite important later on in the development of a particular medicine or whatever. And wearing my kind of quintiles lanyard as I was earlier on, I guess there's also a question of what's the role of contract research companies in all of this, and whether we can make better use of that. So second question is, are we clear enough about what we want to achieve in terms of this wider participation and uptake in studies? And then my third question is whether there's still a kind of hearts and minds issue to be got over. It seems to me that there's people in the NHS particularly have moved a long way in the last 5 years, starting particularly with the most research active institutions, but I think increasingly commissioning groups and others in terms of their approach towards working with the pharmaceutical industry in particular. But it's important. Academic departments do need to be concerned with the academic outputs of what their colleagues are doing, not just the income they generate. Commissioners and public health departments absolutely need to be concerned with the public health impact of the work that people are doing. Health economists and the various other kind of nice interlocutors, if you like, need to be rightly concerned with the strength of the evidence base. And so when you add all those things together, it seems to me we need to ask ourselves the question about whether we've got healthy scepticism or whether we've got a bit of blind prejudice along with that. So those are my three questions. My proposition, if you like, to float is not a new idea, but is around data linkage, and it's not a new idea, as I say, but I think it is potentially a big idea whose time has come. And people have observed for a long time that the NHS clinical record is a resource that's underutilised, and yet is unique probably in the world. And I think this combines with some of the economic pressures on industry to find alternative approaches to evaluation in certain circumstances to the randomised controlled trial. And I do wonder whether this is something that initiatives like the Academic Health Science Networks could really focus on and motor with. that you know, there's a lot to be learned in the experience in Scotland and indeed in Western Australia, and certainly I know which I favour in terms of the site visit. But I think that the point here is that that making data work across organisations and across sectors into the criminal justice sector, into education and so on, is something that can only be done by organisations and can only be done by organisations working in networks, and therefore isn't something that centres of excellence alone sort out, or that individual clinicians and researchers can do on their own. So I kind of float that as an idea that might be a useful focus for some of this activity, so that in looking at the opportunities of these networks in particular, we don't end up with old wine in new bottles, just rehearsing the same old arguments, and we are actually trying to do something different.
Okay, thank you, Miles. Laura, from the patient's perspective, what do you make of all this?
Well, I'm coming at this from a completely different angle again.
Good.
This is a real first for patients involved in NICE. I really wanted to, I hope it's not the last, but I just wanted to say a bit about PIN and what we're about. We are committed to helping patients and patient groups engage productively with NICE, and we do help to ensure NICE puts patients, carers and patient groups at the centre of its work. We're independent from NICE and the pharma industry, and we like to think of us as a critical friend to NICE, really. The theme is collaboration, and in my view, if we're to be truly collaborative, then I don't think it is the case that NHS and industry can improve patient outcomes alone. The truth is, I don't believe we can even define what outcomes we should be improving without meaningful involvement of patients and patient groups. So we really need to be seen as an equal partner, and that's my take-home message for you all, really. There are three things I believe we could do to improve patient outcomes by working together. The first is to have integrated guidance from NICE. The second is ensuring guidance is developed in response to need. And lastly, earlier engagement of patients and patient groups. But before I give you some examples, I would like to give you some questions first. Outcomes. We've heard a lot about them, but what are they? What role do they have to play in improving patient care? And are outcomes just the latest buzzword in policy, or are they a replacement word for targets? How are outcomes decided upon, and how should they be measured? What is the value in focusing on outcomes? And are some outcomes more important than others, and if so, why? The proposed set of outcome indicators for clinical commissioning groups roughly reflects NHS programme expenditure, that is, with the exception of neurology. Neurological conditions cost the NHS 4.3 billion, that's 4% of total expenditure, but have secured no outcome indicators. Why might that be? Whilst I don't hold many answers to these questions, I believe outcomes are becoming more and not less important in improving the delivery of care across the health and social care divide, yet our national policy agenda does little to encourage this. Who can name all the outcomes framework that exist? I'm about to test you all now. We have an NHS outcomes framework, a public health outcomes framework, a social care outcomes framework, a commissioning outcomes framework, a quality and outcomes framework, and we're soon to get a long-term conditions outcomes framework. We have outcomes overload. One might question whether such a plethora of frameworks is compatible with integrated care. How about this for an idea? Rather than have multiple frameworks, should we instead build a register of actual health outcomes by condition, backed by some universal descriptors of quality care with financial incentives to achieve the health outcomes that really matter? We like to talk about it a lot, but how will we move integration from political rhetoric to reality? If we accept that this could be one of the single greatest things we could do to improve patient outcomes, and NICE's core role is to set out a vision of what high quality care should look like, then there is a real opportunity here for NICE to lead the way in producing integrated guidance. In 2006, NICE published guidance covering health and social care aspects of dementia. This should have been a model for future guidance, yet this model has never been replicated. Are NICE inadvertently reinforcing the artificial division between health and social care? At a recent NICE board meeting, I asked whether NICE felt it had created a dependency culture. Without a clinical guideline for a condition area, there will be no quality standard. And if there is no quality standard, there will be no commissioning outcome framework indicators either. NICE has to go on evidence, and therefore the message from NICE was that patient groups should publish their own accredited evidence source for use as the basis for the development of future guidance. Like all things that NICE does, this would appear to be a rational and logical approach, but to respond to where there is an evidence base only risks reinforcing the variation that already exists. For example, this discriminates against those patient groups who don't have the resource and capacity to get ahead. Also, if NICE's central ethos is about reducing variation, it needs to be responding to need when developing guidance rather than simply where there is a convenient evidence base. Otherwise, NICE becomes a barrier to improving patient outcomes. The Guardian recently claimed that NICE could be the saviour of the NHS if it could only insist on its decisions being followed. This would ensure the NHS is national, not fragmented, with the same menu of effective treatments available everywhere. One might ask what the point is of having national standards if their implementation varies locally. There are two major areas of policy that will affect implementation. We've heard about them over this conference. The first is the Health, Wealth and Innovation Report, which aims to reduce variation in the NHS and encourage innovation. And the second is value-based pricing, which in DH language aims to improve access to effective and innovative drugs and give patients and clinicians greater access to clinically and cost-effective treatments. Both have huge implications for how treatments are valued and made available locally. Both ultimately aim to benefit patients, but neither programme has involved or attempted to engage with patients and patient groups. Yet patients are the intended beneficiaries of both of these policies. These debates are technical, but they're not beyond the reach of patient groups. We have an important role to play in shaping, implementing and communicating these policies. But in order to do this, we need to be seen as partners and not end-of-the-line consultees. Patient groups do have a lot to offer. Many of us offer information, professional education, mutual support, research, the list goes on. I'd like to give you one example which, although specific to MS, is transferable to other conditions to illustrate the potential of collaborating with patient groups. For those of you who work in the NHS and industry, you may have heard about the MS Register. This is a unique research tool which combines information from patients, such as patient-reported outcome measures, with clinical data and routine NHS information. Not only does the register have the potential to transform the delivery of care and services for people with MS, it will help with the setup of targeted clinical trials. In addition to this, the Society is piloting a survey which aims to give a comprehensive picture of the needs of people affected by MS on a national level. This will include how needs and service provision vary geographically. We will use this to inform how we work with commissioners when developing services. So I hope you agree that this work illustrates potential areas for greater collaboration across NHS and industry. Patient groups are more than just stakeholders, we're also partners, and I am very passionate about making sure that all patient groups, whatever their size or capacity, should have the know-how and expertise to be productively engaged in NICE processes. However, I can't do this alone. NICE must also be willing to facilitate engagement and do something different as a result. I'm proud to say that we're going to be putting on a range of free workshops this year for patient groups aimed at helping to improve the quality of engagement between patient groups and NICE. And I'd like to extend a very large thank you to the patient and public involvement team who've been a huge support. So in summary, I think there are three things we can do to improve patient outcomes. If integration is to become a reality, integrated from guidance from NICE would be a good place to start. Secondly, NICE needs to respond to need instead of where there is a convenient evidence base. And thirdly, we need to involve patients and patient groups at an earlier stage, seeing them as an equal partner in both shaping and implementing policy. Thank you very much.
Okay, very powerful stuff there, Laura. Thank you. Can we have a nice response to this? Because you sort of laid down the gauntlet there, saying that we need to integrate the guidance and indeed the quality standards, I guess, and then based on need and involve patient groups earlier. Who from NICE would be happy to respond to that? This would be good. Don't stare at your feet, Michael. That won't do. Show us what progress has been going on. Who are you nominating? Michael's just pointing his finger now. He's delegating. He's doing terribly well. Mercy is... Okay. So Laura says progress has been made, but more progress could be made. Well, what about, there are 3 points we're talking about. Integration, basing the guidance on need and involving patient groups earlier.
I'd sort of, well, I would agree with that. I mean, it's about, I guess, making sure that we move towards it. And we have had debates for many years about, you know, what we can do. And I think earlier we spoke in the conference about looking at, you know, instead of just looking at condition specific, but Mike's dream of this comorbidity as well, which is another quite important thing. I think pathways is our first step towards integration of you know, what we've already produced, but also looking across different conditions too. I think one of the things, I mean, I've worked in patient advocacy for the last 20 years, and the reason I'm still around NICE after 10 years is because they're one of the only NHS organisations that do it very well. And saying that, we're always trying to improve it as well. And you mentioned, Laura, the other reports that are out and issues like value-based pricing. And I would encourage government and others to, you know, to actually make patient-centred care a reality. Because I often find, as I said, I'm a carer and take my mother to St. George's, actually. You know, that that's not always a reality, that patients are the afterthought, they're the consultees at the end, and yet they, you know, their experience really should be at the heart of good quality care. So I completely agree with all those things, and I think by working together, we can be one of the actors in actually moving your vision forward.
I think we need to clone you, actually, Laura. We need about 50,000 Lauras just checking that we practice what we preach. What about the point that Laura made more widely about we're just in danger of being engulfed in a tsunami of outcome frameworks everywhere? Who thinks actually they're the same as targets under a different name? We've got one or two cynics. So let's hear from this gentleman. Let's have a little dose of cynicism before we become constructive again. Would you like to tell us why you think they're actually not much different from targets?
I think that in terms of what I've heard, that the targets are being replaced by the outcomes, but there are unquestionably targets related to those outcomes because that's what has to be achieved. So it's just a different terminology.
Okay. How many people feel more constructive about this idea of outcomes, and this is precisely what we should be focusing on? Who actually thinks this is a good thing? Okay. So we're generally sort of slightly more optimistic about the idea of outcomes. Are you reassured by anything you've heard there, Laura? Do you think, I mean, you've been involved in NICE, I know you're separate from NICE, but have you seen progress in your time since you've been there? That the patient voice more to the centre and there is more collaboration?
I think there definitely is. I think there's further room for improvement though. I think NICE always say they want to involve patients and they want meaningful engagement, and I think part of achieving that perhaps is being more transparent in the guidance that NICE produces. I think in addition to the workshops, NICE could be much clearer about what they want from patient groups. For example, I've been involved in a few technology appraisals now, and I've very much felt that my input has been to make sure that any models being produced by NICE, that I'm acting as a check really against the assumptions that are going into that model. What NICE aren't really that interested in is my case study of someone with MS who's had that treatment and what impact it's had on them. And that's fine, but just be honest about that and be clear about what it is you want from us, because we want the same thing. We want very good guidance for patients. We want good quality guidance. So just be clear about what you want from us, and then we can do more to help you.
Okay. Stephen, let's quickly ask you about what restrictions are placed on the industry and the strategies they can use to collaborate with patients. Because I suspect, how many people here have actually read the ABPI code in its latest version? If we did a multiple choice on the ABPI code, who actually, to be honest, wouldn't have much of an idea what was in it? Okay, so most people. Does that depress you slightly?
It doesn't depress me. I think the code of practice is very important. I mean, it needs to be recognised as an industry we are very heavily regulated and very heavily controlled. And we do have a lot of close relationships with patient organisations, both at the industry level through the ABPI, and also specific companies that work on specific medicines, specific products. Those relationships are very, very carefully monitored and managed. The code of practice is quite strict about that.
Okay.
And
is it too strict, do you think? Or not strict enough?
Can I give a personal view?
Yes.
I think in the day of the internet and the day of all this proliferation of information being exchanged by all sorts of people, I think the industry feels somewhat hamstrung that we as an authoritative source cannot say what we need to say about our medicines. That's my personal view. You go through, just log on and search on any medicine, you'll see that the company itself can say very little about it. And I think that is a problem, because as our reputation has improved, I think it is right that we should be able to say a lot more than we're saying. I do not believe in direct-to-consumer advertising. I'll put my hand on my heart and say I don't believe that is appropriate in a European context. But I do believe we should be able to have a more free-flowing flow of information between ourselves and patient organisations specifically, and also at times patients, because compliance is an issue. We know how many medicines are wasted, and I think the industry has a role to play in that specifically.
So when you develop a new medicine, do you think there should be an adherence or a compliance plan that goes with the development of a new medicine?
Yes, I do. Okay. Yes, I do. I think it would save a lot of money. I think it needs to be done in partnership with healthcare professionals, in partnership with organisations like NICE. But we are missing a trick there, particularly when there's this proliferation of information out there, and the code of practice disallows us to take part in that. So I think there is some work to be done. Yeah.
It's interesting, isn't it? In Sweden, the most comprehensive and trusted source of information about the pharmaceutical industry is provided by the pharmaceutical industry. It's funded and monitored, and everybody goes there and trusts it implicitly.
Yeah, absolutely.
How do they manage that without accusations of vested interest?
Well, having been to Sweden quite recently, there are accusations of vested interest. But I think it needs to be done at arm's length. I think we need to review and look at what patients want, do it in collaboration with patients, with the MHRA, with bodies like NICE, with the NHS itself, because everyone is hamstrung about what can we say about our medicines, and a lot of our member companies are not even aware of the freedoms we currently have, because then compliance departments simply say you can't do it, we're not prepared to take any risk, which means in that context the code is not working correctly either. So I think the code is always a moving feast, and it should be, because it has to change and respond and adapt. One of the areas that we do feel greatest frustration of is relationships with patient groups, and also information we can give to patients, not about promoting medicines, but about adherence to medicines more than anything else.
Okay, let's just quickly come on to Miles's points. Academic health science networks. Who's never heard of them? Put your hand up. You've no idea what an academic health science network is? Excellent. Who thinks they're an opportunity? Who's really excited about them? Put your hand up. Okay, who thinks they're actually confusing things more and unnecessary? Okay. Does anyone want to talk about them? It was one of Miles's big questions. He's thrown it out to you. He wants to know whether they're an opportunity or a complication. Anyone want to answer that question for Miles? Yes, this gentleman here does. He was one of the ones who'd never heard of them, so I should... Tell us who you are and what your point is.
Yes, Tom Treasure, and I've followed this debate with some interest. If we are going to get patients into studies and produce real-world valuable data, and by that I would include randomized controlled trials, and in surgery, and I'm a surgeon, that's extremely difficult. The patients exist all over the country, in district general hospitals, whereas if you put your target into centres, you will not capture them in big numbers. So I have felt for some time an emphasis on widespread involvement with research in all sorts of hospitals is how we will do clinical research. Translational research and lab research is different, but the resource for clinical research is all hospitals, not specialist centres. So that's an idea I'd like to engage you with.
What about the particular point that Miles made, that actually industry particularly likes working with people it's always worked with and the key decision makers, and that some people might get preferential treatment and others find it hard to get into that?
I think that's true. Inevitably, if you're studying cardiological devices, you need to go to where interventional cardiologists work. But I'm talking about, it's not that that's wrong, it's that there is another wider sweep of patients all over the country with lung cancer, the commonest cancer. There's not a single randomized trial recruiting at the moment of the surgery on lung cancer. And bold statements are made, and many of them can't be supported. And you will only get them if you engage with a culture of research in all hospitals, not just at the national flagship institutions.
So research almost has to be seen as a given. We should all be
absolutely.
doing it. Okay. Stephen, coming back to that point that the industry often has preferential people it likes to collaborate with. Presumably the flip side of that is that I've been to meetings where the industry has talked about recruiting and huge amounts of money is wasted. A lot of centres, you spend an awful lot of money trying to recruit and sometimes people don't deliver. And it's a hugely expensive thing. In a sense, there's an understanding why you would go to centres where you think they're going to be better at recruiting. And
I think it's an interesting allegation. I think what I would say, if we step back from this and look at what the Office of Life Science produced in December that was announced by the Prime Minister, to say try and make every NHS patient a research patient, I think we need to look at the league tables of performance of the UK as a whole, because we've gone down from 6% global share of phase 3 to just over 1%, and that's happened in 10 years. Now, the reason for that is speed to recruitment and speed to completion. And the reason for that is needless replication, duplication by ethics and also by approval boards at the trust level. So you go from trust to trust to trust, which is one of the reasons why the industry tended to go to those places that they knew got the quickest approval from. Now, we've been working quite aggressively with the NIHR and AHR and also with the new entity that's coming to this, the HRA, to make sure that one approval by one body should give everybody the approval without replication at each trust level. We're also working with clusters of trusts, including Birmingham, which is pretty far-sighted in this. And there's a cluster of trusts that have got together saying, we recognise your approval as our approval, so we can have multiple centres recruiting at the same time. And we have got, I mean, there were some pretty horror stories. Sometimes it was taking 365 days, which is a year, to recruit the first patient. Now, by that point, the trial may well be over in Germany. So it's a competitive advantage that we should be utilising, because the NHS offers an integrated system that has not been effectively utilised. It is a potential revenue stream for the NHS, which is one of the reasons why people are waking up to it. And I personally, like Lord Drayson, for example, said the UK should forget phase 3 studies. I do not believe that, because I think we have a unique opportunity. They won't all go to China, they won't all go to India. Firstly, often the data is not suitable for utilisation in countries in Western Europe. And secondly, I do think we have a unique opportunity. It's often not cost-driven, it's speed-driven. That's the problem. It's often not about the cost, because it will be more expensive to do your trials in Germany, the UK, France, than China or India. But that's often not the issue. What you want is the credibility, and often what you want is speed of access, recruitment, and delivery of the data. And we are working collaborative to make sure that happens. So we're adding more trusts to that list. I think the networks that Miles talked about will be very helpful. Anything that draws attention to this will be helpful. And it is a critical need. And we're missing a trick as a country. You know, we spend, as an industry, we spend 10% of our global R&D in the UK, yet the UK is only 2% of global market share. So disproportionately, we're reliant on it as an economy, as a country. And I think I want the NHS to be getting more of that R&D dollar. The translational stuff, the early stuff, is something I'm not overly familiar with the issues, so I won't comment specifically on. But the phase 3, we need to start being better at it, I'm afraid.
Miles also made the point that the NHS clinical record is pretty much unique, particularly if you want to follow Mike's dream to do guidance for people with comorbidities. Do you think that's hugely underutilised at the moment? I mean,
absolutely. It is a huge opportunity, but it is a technically complex thing to get the most out of it, and particularly I think with the consolidation of general practice into a completely electronic record, and very often the same electronic record across quite large areas, there are huge opportunities. But I think most places need to learn from, as I say, Western Australia, Scotland, and so on, in order to understand how to stitch those up for the benefits of research, and also how to link them then to education outcomes, criminal justice outcomes, and so on. I think it's potentially very exciting field.
Laura,
yes,
you can.
Because there is I'm an Englishman, and there is the Scots always keep saying they're doing it better. They're measuring it differently, is what I would say. Just to be sure, just to be clear, because some of the English data, and I say this on behalf of some of my favourite NHS trusts, say it's not fair because they're measuring the data quickly and we do it better. Just to...
I do love the Scottish. The Scottish think they have the best NHS in the UK, and they also have the lowest life expectancy. Which is a hell of a trick, isn't it? I was up at the Edinburgh Fringe this year, and I always have a gin and tonic when I'm at the Edinburgh Fringe just to annoy the professional Scots people. And I went into my local supermarket and trying to find a lemon. There was one lemon in the entire supermarket in the exotic fruit section. So they have their own problems in Scotland, I would say. Laura, the point I was putting to you is, do you think the general health literacy of patients, getting patients involved in clinical trials, there are always, particularly with the clinical record, there's scare stories about breach of confidentiality, etc., etc. Do you think generally the level of health literacy amongst patients in patient groups is quite high and they want to be involved in clinical trials?
I think just never underestimate patient groups. The MS Society's got a fantastic research network. There are about 300 individuals on that with MS who are working with researchers, who are influencing how we set up trials, what research we prioritise. You know, they deal with some quite technical stuff, but I think if patients and patient groups are given the right support, there's no reason why they shouldn't be able to do that.
Okay, we've got time for some questions from you. A couple of questions from the audience on what you've heard. What do you fancy? Yes, I've got a question here.
Thank you very much. Good morning. My name is Hamera Sultan. I'm a registrar in public health at Stanwell PCT. It's not a question so much, Phil, it's more of a comment. I've been working quite a lot with patient groups locally in terms of leading research collaborations, going through NIHR. And what we found is that the whole process is very, very long. We get a lot of engagement with patient groups. And then the time it takes to get bids seen, shortlisted, longlisted, and so forth. And then you get that decision at the end of the day that, sorry, you weren't successful. And a lot of the patient groups that I've worked with have been quite frustrated by that process, all the work that they've done. So we've got a slightly different tack in Sandwell in terms of kind of doing more local research, using our own resources, and still doing high quality evaluations that aren't necessarily RCTs, but are still a good quality that do show that we can improve patient outcomes. So I just make a plea that, I do think there are, and that there is a place for RCTs in this world. There's still a lot of work that can be done locally without having to go through all major funding organisations. I'm not sure what the panel think about that.
Okay. So the actual process, well, you would know this, even the process of getting major RCTs funded can be quite torturous, presumably from your perspective and also from the researcher's perspective.
It can be quite torturous, but I do support the opinion, which is you don't have to start national, you can start local. So I would endorse what you just said. And also on the patient groups, you have some outstanding patient groups like the MS one, which clearly have very active and very motivated patients. And you have other patient groups that are somewhat more amorphous and less driven towards research and less capable. So MS, HIV, these are areas where cancer, you really see people pushing on it and wanting to be part of a trial. 1 in 6 cancer patients in the UK is on a clinical trial. And we should remember that because there is a lot of patient activity, and patients typically, particularly with the more frightening diseases, are much more willing to take part in clinical trials.
Miles, as sort of chief executive at St George's, how permissive are you in allowing people time to do research? Because Tom, weren't you originally at St George's? So if Tom said it's really important we do a surgical trial on the treatment of lung cancer, and et cetera, how collaborative, how permissive are you and all the other targets and financial restrictions based on you, how easy it is for you to allow clinicians to do high quality research within your organisation?
Sure, I think it's important, particularly for organisations like St George's, to see research as part of our core purpose. It's not, we're not a healthcare provider that kind of does bits of research as an add-on if we have the time. It is actually part of our core mission. And so we encourage people, we work with them to identify time and resources and so on. I think we need to be realistic about what every organisation in the NHS can contribute to research, and it will vary. And I think we need to move beyond the kind of just general exhortations that every patient should be a research patient, or every organisation should have the NIHR performance metrics as the kind of top item on its performance agenda, into a kind of a slightly more sensitive sense of what does each organisation's engagement in research really mean, and what can it mean.
Okay, we have time for one more question, or yes, just one more question here at the front.
Hi, I'm Nicola Glenn. I'm Quality and Performance Manager for a social enterprise that's health and social care based. From a quality and performance point of view, we've got two streams of work going on nationally, the enhanced data sharing model and the community information data set. I'm just wondering if there's anything we can do in relation to the use of clinical records and research that could tie into either of those streams of work.
Okay. Any thoughts on those? Or? I think they don't know is the answer. Explain a bit more what you...
With the enhanced data sharing model, every patient will be asked the question whether they will opt in or opt out of sharing the information within their record.
Okay.
So surely couldn't one of the questions that be asked whether they would be happy for it to be shared for clinical research.
Is that not asked at the moment?
No.
Oh, right. Well, that would seem a fairly sensible thing to do, I would have thought.
Yeah, and there are places where people are doing that kind of thing. So at South London, the Maudsley, for example, they're working through a system of, I think what they're calling presumed consent participation in research, where they consent people on a kind of fairly generic basis, and that they're then able to use those people's data in a variety of studies.
Okay, final statement. The one thing that could improve collaboration between patients, industry and the NHS, what would your top of your wish list be, Stephen?
Trust, I think. Trust, okay. Mutual respect. Trust and mutual respect, and follow nice guidance.
And can we trust the ABPI?
Yes, you can.
Excellent. Okay. Miles, what was the one thing you...
I think for me there's been an absolute sea change in the interest of the kind of NHS hierarchy, if you like, in research in the last few years, and anything that maintains that, I think, is really important. We can talk about lots of different initiatives, but I think it's that top of the office focus and that sense that research is important to the NHS and isn't just an add-on.
Okay.
It's something to maintain.
Excellent. And what about you, Laura? What would your take-home message be?
I would say don't forget about patients and patient groups. We have a lot to offer. See us as an equal partner. And one take-home message for NICE, don't produce separate health and social care standards, produce integrated guidance. Okay.
We're going to go to refreshments now. Don't lose your keypads. You're going to need them in the 12:10 session.